Hey guys, in this video we're going to talk about how to respond when you get a call or a page about one of your patients having chest pain. This video is aimed at you keen bean medical students and junior doctors. So we're going to talk about the 4-stage response to this chest pain call. That is the first stage when you get the page or the phone call, the questions you have to ask, the walk over where you go through a lot of the differentials that it could be, then the kind of bedside review of the patient and the notes, and finally the management of the things that could kill your patient that you need to pick up on. Usually you'll get a page, bed 3.1, MRN has chest pain, please review. You can call the nurse if you're not on the ward. If you are on the ward, you can just go over, but you can call the nurse who sent the page. And this is an incredibly important phone call because the goal of the phone call is to do a couple of things. A, it's to understand the problem. What is the problem? Understanding it as best as you can over the phone. Then B, it is to triage the problem. How quickly do you need to go see this patient? Is it urgent, so you put down the sandwich and run? Or is it, all right, I can finish this sandwich. So really it's the sandwich test. It's whether you have to put down the sandwich and run, or can you just keep eating your sandwich? That's how you triage. And C, the final purpose of the phone call is to get the ball rolling, okay? You can ask the nurse to do some things for you before you even get to the bedside. So in terms of A, understanding the problem, what you want is you want to know the patient, you want to know why they're in hospital, and you want to know a full set of vitals. And then finally, and this is a super important question, you want to know if they look sick. Nurses and the clinicians in general are really good at telling you when someone just looks sick, when they feel that something is just not right. And if you have a story that it's, a 65-year-old guy who's coming in because he's got heart failure, he's got a history of, previous heart attacks, a family history of heart attacks, and he looks sweaty, clammy with chest pain, then, obviously that's a put your bloody sandwich down, go to the bedside, and you can ask for some things over the phone straight away. Whereas if you have a story of a 25-year-old guy who fell off his bike and has a known rib fracture and he missed his last dose of analgesia and he's getting a bit of chest pain, then likely it's probably, you can finish the story, you can finish your sandwich in that case. So what are some questions you can ask over the phone to get the ball rolling? Well, first and foremost, and often forgotten, is just get a computer on wheels by the bedside with the patient notes up, okay? That way you can go straight there and you can get all the information at one point. You don't have to waste time running around the ward looking for a computer. Some of them aren't, turning on, some of them are out of battery. It can be quite a nightmare. So there's practical tips like that. Also get the chart at the bedside. You can also start investigations. Ask the nurse, can they get a cannula in? Can they put an ECG dots on and start an ECG? Nurses can initiate oxygen, at least by nasal cannulas. If they're hypoxic, you can make an order to escalate that. And you can also ask them to start preparing some of the medications, such as nitrates or opioids for the pain. So once you've finished the phone call and you're kind of got an understanding of the severity of the situation and how much of your sandwich you can finish, you can
start walking over.
Whilst you're in the elevator, whilst you have a bit of time, you can start running through some differentials so that you don't just lock into one thing and then get blindsided when it could have been something else, and maybe it is something else and you should have realized that earlier, and yada, yada, yada. So keeping that broad list of differentials, the walkover is really useful because you can go through them. Now, the method that I use for differentials to chest pain is this awesome kind of what would you call it? Like a thought experiment that was devised by the online MedEd guy. And essentially you just imagine an arrow going through a chest and there's a differential at every single anatomical structure the arrow goes through. Okay, and that's how you get the breadth. So that could be skin, so a prehepatic neuralgia. It could be bone, so that could be a fracture or costochondritis at the joint. Then you got the heart, so obviously plenty of pathology in the heart, and that could be in the pericardium, in the actual myocardium. It could be obviously an infarct. Valvular issues don't normally cause pain, so endocardium less likely for pain. But it could be anything wrong in the heart. Obviously that's lungs, so that usually presents with pleuritic pain. That's a bit of a different character. So consider the lung pathologies like emboli or pneumothoraxes. And of course the gastrointestinal system, like the esophagus that goes through there as well. So ruptured esophagus, spore halves, even just gastroesophageal reflux disease, although that's more of a diagnosis of exclusion after you've ruled out a heart attack, if it's a classical story. And then of course there's a lot of other things that can do it. It could even be psychiatric or psychogenic, I should say. So but those are all less likely things. I think that's how you get a broad width of differentials, but the key thing to remember here is remember the 4 things that'll kill your patient in front of your eyes, okay? That's a myocardial infarct, that's dissection of the aorta, the massive PEs will do that, and of course attentioning pneumothorax, all right?
The bedside review.
So when you get to the bedside, that's when you have to get in the zone. You do the end of the bedogram, so you look at the patient just from the end of the bed and you see, you can say, are they sick or are they not sick? And if they look sick and you start taking your history and you're feeling overwhelmed and you don't know what's going on, call for help, all right? Junior doctors do not need to manage this shit alone, so call for senior help early. But if they're not stable, you need to start doing your A to E assessment, okay? Really focusing with chest pain, you're really focusing on breathing and the cardiovascular system. So making sure they have IV access and that their vitals are stable, etc. Really, your goal at the bedside is to exclude the 4 things that could kill your patient really quickly. So what's the history of the acute coronary syndrome? You probably know it. It's usually an old male, probably obese guy, bunch of risk factors, diabetes, dyslipidemia, hypertension, and then they're complaining about a pain that came on over minutes. It's usually substernal and it can radiate down arms up to the jaw. They might be diaphoretic and nauseous. It's a catecholamine surge that they're getting. And that pain is really their myocardium just starving for oxygen. And actually their examination can be totally normal. All right, so remember that. A heart attack can have a normal examination, except for the fact that they'll look sick and be sweaty. You might not hear a murmur or anything. If their heart is failing, then you might start seeing signs of heart failure, like crackles in the lungs or something like that. But yeah, it can be a normal exam. Now, chest x-ray usually also normal, and on the ECG it can kind of depend, but the classic is an ST elevated myocardial infarct, and that is you go down the reperfusion chart or follow your local hospital guidelines in that case. We'll talk about management in a sec. With pulmonary emboli, the history is usually something that comes on like bang, it's quick, it's seconds. Because you can just imagine there's this thrombus, this slimy worm-like thrombus coming up the veins, going into that right heart, and then finding a vessel that it just lodges into and pop, and then ischemia follows. Now, normally the pain is described as one-sided. It's usually in the area that's affected by the PE. It's usually pleuritic. So if you get them to cough or take a deep breath in, the pain gets worse. They're usually tachypnic, and they'll likely have those risk factors that you've learned backwards and forwards in your medical schools, the Virchow's triad, the Wells criteria. They include being immobile, lengthy travel, not that that's that common anymore because of COVID restrictions, but recent surgery, hypercoagulable states, maybe they haven't been drinking as much, maybe they have a cancer. These all increase your risks of developing clots, or more accurately termed thrombuses. Thrombuses or thrombi? I don't know. I'll Google that later. In terms of the exam, they might have a deep vein thrombosis, and the rest could be pretty much normal. You may, if it's a massive PE, feel a heave, which is just the heart really trying to get past that massive obstruction. So it's an obstructive form of shock. But these people are usually tachypnic and tachycardic and really sick if it's a massive one. Most PEs are not massive and usually not even clinically important. The chest x-ray is usually normal. The ECG is usually just a sinus tachy. There's an S1Q3T3 thing that no one's ever seen, but apparently it's a thing. Then the next important investigation is to decide whether you're going to do a CTPA. So it's a CT of the pulmonary arteries with an angiogram. Or if you're going to, if you're not that sure that it's a PE, if it's less likely and you use scoring criteria like Wells, then you just do, you get a coags tube and you do a D-dimer on that to rule it out. Aortic dissection, usually it's onsets between, it's between seconds to minutes. It's not sudden, but it is gradual. Classically, it's this tearing type of feeling that, and it's funny because that's actually what's happening. It's a tearing of the inner lining of blood vessels, the tunica intima. And unlike usually a heart attack, the pain will go through and to the back. So intrascapular back pain is a classical sign, or symptom, I should say. Risk factors include smoking, they might have high blood pressure, maybe they've got connective tissue diseases. But yeah, on your examination, it's usually pretty unremarkable unless you are do blood pressures on both arms, and you might see that there's a discrepancy if the dissection is affecting a certain part of the aorta after that right brachiocephalic trunk. And essentially you want to talk to vascular or cardiothoracics, and if the patient's stable, they'll need a CT angiogram to kind of characterize the dissection. And if they're unstable, you want to get help. Pneumothorax is a little bit easier because it has pretty clean clinical signs. It'll also have that kind of onset that is pretty quick over minutes. It's usually lateralizing to one side. As it gets worse, you might start seeing signs of heart failure. You might see tracheal tug. These are all late signs. While it's early, you just might get pleuritic pain. On your examination though, you should be able to pick up a kind of resonant, very hyper-resonant percussion. You should hear decreased breath sounds because the air is building up around the lung, and it's a clinical diagnosis, so you're absolutely within your rights to just grab yourself a 16 gauge cannula and pop it in mid-clavicular line, second intercostal space, needle thoracostomy based on clinical findings. If you take an x-ray of a pneumothorax, that just means that your clinical review wasn't good enough. But I guess if they're stable, then you're probably better off doing that. But in the event that they're not stable, pop that needle is it a needle thoracostomy or a thoracocentesis? I'll look into it. I think it's just a needle thoracostomy because you're not pulling anything out there. But yeah, your examination is super important in pneumothorax. If you do see a chest x-ray, you'll see like a collapsed lung with no lung markings on the outside, which is because that's air. I don't know if there's any ECG findings. There might just be tachycardic or signs of right heart strain or right heart failure. Because what happens is the inflated lung shifts the median sternum, which kinks the vena cavas and stops blood flow into the heart. So you just get this it's kind of an obstructive form of shock, isn't it? Because it's pushing it's kinking all the vessels, blocking the blood flow.
Investigations.
And in terms of investigations, it's as a good rule, so that you don't have to think about it too much, just always order a chest x-ray, ECGs, and a VBG.
Management.
The 4 things you got to do. If it's an MI, call cardiology, do all the investigations we talked about, follow the New South Wales chest pain pathway. It's aspirin, heparin, cath lab, essentially. If you're not near a cath lab, if you're rural or something, you might have a different protocol, so keep an eye out for that. If it's a PE, you want a CTPA and talk to interventional radiology about clot retrieval versus thrombolysis therapy, so you want the respiratory doctors and interventional radiology. If it's a dissection, you're doing a CT angiogram, or if they're unstable, an ultrasound, and you're talking to cardiothoracics and vascular. And then finally, if it's a pneumothorax, you're putting a needle thoracostomy in while you buy time to do a chest drain. You're calling your seniors early. You can do a chest x-ray, but make sure you are calling for help early in all these situations. I think that the main job of a junior doctor in all these situations is essentially to triage and call for help if it's anything mildly to very serious. If it's just chest pain because someone's got a rib fracture and you need to chat some analgesia, you don't need to get help. But if there's anything that looks mildly serious, it's your job to escalate it appropriately. So that's the job of a junior doctor, to know when to get help. And the answer of when to get help is essentially the second that it looks pretty serious or, makes you a bit uncomfortable. Make sure you practice how to do your handovers using the ISBA mnemonic. We can talk about that in another video. But for now, that is it for this video. Thank you for hanging around. If you enjoyed it, please hit that like button. And if you want more of this kind of content, please consider subscribing. I hope you all have an absolutely lovely day. Please leave any comments or questions. I'll answer all comments. And I'll see you guys in the next video. Bye.